Let's talk about delirium, and not just in theory, but in real practice, at the bedside, where things get confusing real fast if you don't know what you're looking for. Delirium is what we call an acute confusional state. It doesn't stroll in quietly. It shows up fast, catches you off guard, and if you're not paying attention, it gets worse. Starts with disorientation, but if you miss it, it can progress to changes in level of consciousness, irreversible brain damage, and yes, even death. Let me pause right there. Death. Not just a rough day at work, actual mortality. In fact, studies show that up to 80% of ICU patients experience delirium, and when it's present, it triples their in-hospital mortality rate. That's not a small stat. That's life or death sitting right under our nose. So when you're in clinical and a patient starts acting a little off, you don't wait until the night shift to bring it up. Now, why is it often missed? Because we confuse it with dementia. And yes, the two can overlap, but they are not the same. Dementia creeps in slow. Delirium strikes fast. It's abrupt, sudden, out of the blue. Knowing your patient's baseline mental status, that's your superpower. If your patient was oriented yesterday and today, they're hallucinating butterflies on the wall, that's delirium until proven otherwise. Let's walk through some risk factors. First, there are modifiable ones, things we can actually do something about. Think benzodiazepines, anticholinergics, even blood transfusions. If you've got a sedated patient receiving multiple meds, your delirium radar should be blinking. Then we have non-modifiable risks. Age, a history of dementia, recent surgery, trauma, or prior coma. These are the patients you hover near a little closer, because if they go sideways, it won't be subtle. And here's the kicker. Delirium doesn't just stress the patient. It's terrifying for families too. Imagine watching your parent hallucinate or scream in confusion. This isn't just clinical. It's emotional. It's human. So how do we screen for it? The Confusion Assessment Method, or CAM, is your best friend here. CAM is the gold standard. If you don't know it, you need to learn it. And it's not a once-a-shift kind of thing. Critically ill patients need routine screenings at prescribed intervals. We can't catch what we're not looking for. All right, prevention. This is where nursing shines. The best treatment for delirium is to not let it happen in the first place. So how do we prevent it? We get proactive. Provide therapeutic activities to keep their brain engaged. Keep them oriented. Use clocks, calendars, reintroduce yourself often. Mobilize them early. Get them moving, even if it's just sitting up in bed. Control their pain, but do it wisely. Minimize psychoactive drugs. Don't sedate them into oblivion. Prevent sleep deprivation. Turn off the TV. Keep it dark at night. Make sure they can see and hear. Clean their glasses. Find the hearing aids. Maintain oxygenation and fluid balance because hypoxia and dehydration are delirium's best friends. We've even got studies showing bright light therapy may help, mimicking natural light cycles to reduce confusion in ICU settings. Now, what if the patient already has delirium? Then our job is to identify and treat the underlying cause. Maybe they've got an infection. Maybe they're septic. Maybe they're on 5 new meds nobody reconciled. Whatever it is, fix the root. While we're working on that, we manage the fallout. Prioritize patient safety. Think about fall risk because it goes up drastically with confusion. Question whether any non-essential medications can be discontinued. Monitor nutritional intake. Confused patients forget to eat or drink. Create a calm environment. Dim lighting, reduce noise, limit unnecessary interruptions. Offer familiar cues. Family photos, familiar voices, even their own blanket can help. Encourage family involvement, if safe and appropriate. Implement sleep hygiene, cluster care, avoid unnecessary wake-ups, use comfort strategies, and always keep doing ongoing mental status assessments. Compare what you see to their baseline. Don't chart normal for age if you haven't verified what normal looked like for that specific patient. The good news? If we catch it and treat the cause, many patients bounce back in a few days. The bad news, if we miss it, we could be looking at permanent brain damage or worse. So here's your takeaway. Delirium is common, dangerous, and absolutely within your power to influence. It's not a diagnosis for doctors alone. Nurses are often the first to see the signs. So speak up, document what you see, advocate, and treat every shift like the day you might be the one to prevent a devastating outcome, just by noticing something no one else did.